All right, we are live. And if anybody, I'm here, Marlene PT with Christine Robenalt PT at the Pediatric Telehealth Coffee Hour. So this show was made for therapists to help them reach their maximal potential in a setting that is new for most of us, telehealth. It turns out that the information we are sharing has not only benefited therapists, but families as well. So when we're talking about some of these things, Christine may give some definitions to help families if they're chiming in as well. So today, Christine and I will discuss how primitive reflexes that are not fully integrated can affect child development and movement, even when you least expect it. Not only that, but we will discuss whether or not muscular tone can be influenced. We will also discuss how you can address emotional and behavioral regulation. And all of these topics can be addressed through a technique that Christine has developed through her years of experience and training called Sensorineuromotor Education. Christine, thank you for meeting with me today to discuss sensorineuromotor education and how it can help us as clinicians provide better quality care to our patients. So yay, this is your third time.
Wow, I feel like a regular.
Right? And I know that many of us have learned about primitive reflexes in school and probably still have to refer back to our books to be sure on when they occur and when they are integrated, and some of our books may be outdated. So can you tell me what it looks like, Christine, when a child does not have fully integrated reflexes and examples on how you would address that? But first, just in case parents are chiming in, if you can just go over what primary reflexes are.
Yes, let's begin. So first of all, I'd like to thank many people before me for sharing this knowledge. This is not something that I came up with. It's things that I've taken courses on and read about across all different disciplines, from psychology to gross motor stuff. So people like Dan Siegel, people like Dr. Stephen Porges, Svetlana Mostova is who I'm currently taking trainings from a lot, Dr. Karen Pryor. Lots of people who then have taken information from Feldenkrais, Annette Banal. So there's even Bobath. So information that I'm about to say today, you may have heard in other scenarios. I know I learned about neurogenic inhibition in school, where we're going to create an isometric contraction for 7 to 8 seconds to inhibit that muscle so then we can gain some more freedom of movement. I don't know how many, have you done that kind of strain type of thing?
Yes.
What did you use that for?
I used it more during my clinical setting in orthopedics.
Mm-hmm.
So that's when we talked about more about like counter strain and
yeah.
And that type of thing.
Yeah, I trained with Pete Emerson here in Denver, Colorado, and he's big into backs and necks and spines, and I learned about that through him, and you have used it for years. And then I get into this class talking about reflexes, and they're talking about hold the position against 20 to 25% resistance for 7 seconds. I'm like, that's neurogenic inhibition.
Yeah.
So a lot of the things that I'm going to say, you as a physical therapist, occupational therapist, maybe even a speech therapist know already. What I don't think we understand is why sometimes what we intend to do with the children we work with doesn't work. Mm-hmm. And if you ever come across a kid who physically they look strong enough to do what you're asking them to do, developmentally they should be able to do what you're asking them to do, but they just won't do it.
Right.
They scream, they cry, they thrust themselves into extension, and you're like, I don't know, it worked for every other kid.
Right.
So what do you do in that time, Marlene? What would you?
Yeah. Well, and that was also one of my questions, like, is that an automatic sign when you're trying to position them in certain positions and they're extending and not tolerating it? Is that cue you that maybe their reflexes aren't integrated and they're not comfortable in those positions?
Yeah, so we'll get back to that question, but that's a great way to start thinking. To start thinking what's going on. I think sometimes parents, and I'm a parent too, I've got 3 of my own children, myself included, is dealing with a nervous system that is not fully matured. So, and when I say that, I honestly, I'm very serious with that. I'm very klutzy. I run into things all of the time. So my body awareness, I joke, if I ever had a stroke on the right side of my brain, I'd be in big trouble because I have like 0 body sense as it is. So then I would have no spatial awareness. But yeah, that's the way to be thinking about it. And I think as parents, as people, as therapists, we automatically go to, well, the child just doesn't want to do it. So we can kind of notice those thoughts in ourselves, and that then from that, the child doesn't want to do it, but I want them to do it. So we're going to do it. And I'm going to figure out a way. And maybe we try to make it more fun or entice them with a reward. And maybe it works. Maybe they do actually buy in. And that's what we need. We need their buy-in.
Right.
However, because of these underlying reflexes, because of the neural pathways that didn't develop or other ones that did, their experience with their environment is very different. So, right. Primary reflexes. All humans and really all animals have these basic reflexes that are, for us, we're going to refer them as primary reflexes. Other animals might not call them exactly the same. They're not going to look exactly the same as ours. But they're really for protection and survival, first and foremost. They also lay the foundation for more mature motor movements and talking, thinking, emotional regulation, neurotransmitter hormonal regulation. So all of our systems, we consider it kind of like a blueprint. And this blueprint is actually encoded in our DNA. So then if it's encoded in our DNA, the way that our reflexes are going to present, would you then surmise that children who have genetic differences may present differently with their reflexes?
Definitely. Yeah.
What do we see? With every single genetic disorder, what's the first symptom that it's lists on there? It starts with an H.
I guess it depends on what the underlying neurologic condition is, like whether they're
like a genetic change. So
genetic
like
change, okay.
Even like trisomy 30, any genetic change, Soto syndrome, Angelman syndrome, all of those, the first diagnosis or symptom listed hypotonia.
Okay.
So not all children who have hypotonia have a genetic disorder.
Right.
If you have a genetic disorder, most likely that first symptom is hypotonia or may have learning disabilities.
Right.
And so we're thinking about, well, what's going on with that? Well, it begins with these primary reflexes presenting differently.
So are you saying hypertonia or hypotonia? Hypo, okay.
Yeah. Now we can look at the other side too. We can look at kids who have cerebral palsy, who actually do have disruptions in their nervous system, at the central nervous system. And we have conveniently divided that out into central nervous system being our brain and spinal cord, and then peripheral nervous system being the nerves that come out from there. But I think that's a nice category to think about from a scientific perspective, but from an actual how I really move my body and how I understand the world, it's the same. The central nervous system controls all of that.
Right.
Information doesn't just flow one way. So, I am always learning from my internal and external environment. And through my 10 senses. So tell me the senses that you know about.
Okay. Oh man, I'm getting quizzed here.
oh wait, hold on. I'm taking a reflective supervision class right now.
Okay.
So my coaching style has really just
I'm like, oh man. Okay, so let's see. We have smell, vision, hearing, touch, vestibular. I don't know if
Okay.
that's, so let's see, body awareness. I'm just kind of going into like proprioception. Yeah.
Taste.
Taste. Did I say smell? I think I said smell.
Yep.
Let's see.
So we're up to 7, and I can tell you 10.
Let me see. I may need to call a lifeline. No.
Okay.
Let me look on the chat too to see if anybody. Okay, no one's commented.
No problem. So there's 3 other ones here. So the sense that you and I have together, that interpersonal sense. If you immediately think that I'm a good person, or if you're a little bit wary of me, but we know this, we can see even how our own children act with us versus other children.
Right.
It could be that same day, it could be within that same hour, and you leave the room and they act completely differently. That interpersonal sense, that energy that they get that from somebody else, changes their behavior. Why? Because we take information in from our sensory environment. And if I feel safe and comfortable with you, I'm going to act differently. Sometimes that would look like I act so, like I'm so relaxed that all of my insecure behaviors come out, right? I act naughty with you because I'm just so like comfortable and safe, and I know or do I act really rigid and quiet and small and well behaved when I'm at a friend's house or potentially in school sometimes. So that interpersonal sense, also an intuitive sense that I know what to do in this situation, in this environment, overall. And these are perceptions. How I'm understanding this is perception. So as it was a child, we had a tri-level home with the side door between the basement stairs and the upstairs. And every time at night, if it was dark, I wouldn't walk down the stairs normal because there was a window there to the outside. I would crawl to go underneath the window and to crawl down. Now, if somebody was looking through the window, which of course nobody was, they would have seen me. Yeah. But my perception was that there's somebody watching me, and in order to get downstairs to get whatever I needed to go, I needed to crawl on my belly. I had to do this odd, convoluted way to move to be safe.
Right.
So yes, there's a reflex that's being hit. My threshold is being hit. I don't feel safe in the moment. I'm doing something to protect myself, even if it doesn't make sense.
But that's a good point, because we learn about six senses in school, right? And now and if you think all those other senses that you named, and then I just went into my PT, like proprioception kind of thing. That makes sense, because those are our reflexes to help with survival, because that's also what reflexes are for, right? To help with thriving and surviving.
Yep. Yeah. And there's one more, our interoceptive sense. And OTs may have heard about this, and some PTs might too, but how we know what's going on inside of our body. How you know you're hungry, we could say, well, that's proprioceptive in the sense that your stomach is contracting or grumbling or something like that. But really, it's more of a neurochemical issue that you're hungry, a drop in your blood sugar or insulin, different influence, or, for women, how your personality changes during a certain time of the month. Are you really
right?
No, that's not who you are, but you're feeling a chemical change hormonally, and your behavior is different. So again, you're responding to your internal environment. Now, some people are better at self-regulation than others, and I'm honestly, so I bring up these examples because I really think it's important to kind of understand how we are all sensory beings.
Right.
There are absolutely children who struggle so much that they can't get through their day. And when that happens, we definitely want to be intervening to support the parent and the family to move to the next step and to help them be successful and feel safe and social. Then you're going to play, then you're going to explore. And that calm and alert Those are
Right.
words that we've used maybe for school or in parenting or in therapy, but that's what we're talking about here. So every time that you might have said, I want your child to be calm and alert, you're asking them for self-regulation. It's not something
Right.
that we can teach necessarily only with our words. Now, I'm going
Right.
to teach you about self-regulation at 8 years old when you have no idea how to even feel this in your body. When you're so like, I can't stand you touching me. We're fighting an uphill battle if you go in at the cognitive level to teach about something that's sensory.
Right. Yeah.
So these reflexes are here. They lay this foundation, this blueprint. Another analogy would be, we built our house here, and when they were building the house, everything was left up to the builders, really. I mean, we came in, but we don't know what we're looking for. So, they pour the foundation, they frame up the house, comes and does electrical and plumbing and all of that, put the drywall up, they come in and paint. We can move in our furniture, move in my family. I plug in my Google Assistant or Alexa into the wall, hook her up for all my lights and music and all that. And I say, Alexa, turn on my lights, and nothing happens. Is it Alexa's fault?
It might be. No, your Alexa might be broken.
Alexa might be broken. Okay, let's fix that. Let's fix that, Marlene. Let's go ahead. And that's what we do, right? We start there. We start with, okay, let's figure out what's going on. Let's get you an IEP at school, or let's get some testing done and see. All right, well, there's kind of it's working, but it's still not working.
Right.
So we can keep going back and find out that actually my electrician didn't connect all the wiring.
Right.
So that's where the primary reflexes are. Those are those initial ways of how we receive the sensory information, and depending on where our window of tolerance is for that, based off of how our reflexes are presented in our DNA, is how we'll either feel safe in our world or not.
Right. So I like all the analogies that you're using. So I can see how you're saying a child that isn't tolerating positions and maybe doing extension because they don't like it when you're trying to they don't like flexion. So they're extending to like fight the flexions because they don't feel comfortable there, or how those are their reflexes are making them respond that way because they don't feel safe. Is that?
And it's not a safe cognition of, I'm safe here. It's go ahead and spread your fingers really, really wide. So your skin is stretching at this point. Keep stretching them wider. In fact, take one of your hands and bend them back. Is that stretch comfortable for you?
No.
Would you like to live in your world doing this type of stretch?
No.
If you kept holding this, would you eventually maybe start to get irritated, or maybe your heart rate would go faster, or I can even feel like right now my throat is tensing up. So even though right now this is not very comfortable, obviously, but imagine if this was really how it felt for you to raise your neck up against gravity.
Right. Yeah, I would not be comfortable. I'd probably be like fighting it.
Yes.
Get me out of this position.
Or avoiding it.
Yeah.
Okay, what does this look like then? So then we start to see kids with torticollis, and that, so probably in utero that didn't feel good.
Right.
Now, granted, the sense of stretch may have been less because they're already flexed anyway, and maybe they didn't notice torticollis when the baby was small, and then all of a sudden at 4 months they have torticollis. What changes in their drive to move? They no longer are just supine or sideline. Now they're prone, and they have to lift their head up against gravity, past the plane of their body. So a kid who is tight in flexion and rotation here, it may be fine when they're laying on their back. They may be able to tolerate, but as soon as you put them prone, now that's way too much. And then we start seeing the kids who don't want to be there or start rolling over real fast. Because they start rolling over doesn't mean that they have advanced skills, especially when we see them happening too soon. Then they're relying on those reflexes.
And that kind of goes into the next question also, that if their reflexes aren't fully integrated and it's not addressed, and if they get misdiagnosed more of like an orthopedic issue like torticollis, how do you, I guess then it would be up to the physical therapist also to be aware on how they can address the reflexes that aren't fully integrated. So how would you do that if you get a patient? Like, can you give us an example of some of the techniques that you use to address the reflexes?
Okay, so first of all, when I say finding safety, I know a child feels safe when they're in calm and alert. What does calm and alert look like? Again, as an analogy, if I'm watching a television show, I may be calm, but I probably am not alert to other things going on in my environment. So if my husband comes and gives me the grocery list for the weekend to go shopping and I'm watching my show, I might be like, yeah, I got it.
Mm-hmm.
Did I really hear him?
No.
Is there something wrong with my ears?
No. Selective hearing, maybe.
Or
you're just
really
distracted.
not alert to him.
Yeah.
I'm calm and I'm alert, obviously, to the TV, but I'm not really in a calm and alert state.
Right.
So I have a little guy. He's not little, he's 14, but he has a genetic disorder and history of seizures, nonverbal, non-ambulatory. He just bunny hops around. So he's pretty much stuck in maybe a 8-month-old level.
Mm-hmm.
Cognitively, emotionally, everything is stuck right there at 8 months. And so for him, he loves watching the fireplace. He loves watching the fire. And his foster dad is like, he's so calm there. And I said, well, that's great. Go ahead and do some of the neurotactile techniques that I taught you and see what happens. Immediately, the kid went. So that would be kind of like a survival mechanism. Like, what?
Yeah.
He's really not calm and alert, accepting information. He's
Right.
still stuck in a reflexive, like, protection at that time. So more of a stimming type of, maybe trying to get himself back to calm and alert, but not there yet, not receptive to other information coming in through his senses. And so, be careful with just calm. Now, of course, if the child is running around the room, that's not calm or screaming. And we know as parents, we know that if our own children are throwing a tantrum, you can't tell them what they did wrong.
Right.
They're not listening.
Right.
Again, they're in survival mode and they're fighting against themselves. Like, I can't stand the way I feel. And so this is, can I share something on the screen?
Sure.
Let me get it ready for us while we talk here. So it's, oh, sorry. So I think, there we go. So I think that this is where we can unite our gross motor activities with our behaviors or emotions and thoughts and all that. And no matter what age you are, well, like I said, I will say these primary reflexes are going to be developing and integrating in the first 3 years of life. Many of them are integrated in year 1, and others do get integrated in year 2. There are a handful that need to be fully integrated by 3, but for the most part, after 3 years old, if we're still seeing kids struggle, then we know that there's still things going on. But often we see these hard stops. I'll call them like these hard stops with kids who should be integrating a reflex, but won't even go in that position. Right. So at that point, we can look at all the books about reflexes, and then we get confused because we think that something is happening, but then when we stimulate the reflex or we look for the reflex, we see something completely different. So in that case, they're giving us the wrong answer. And I see this a lot with toes, feet and toes. So let's say a 14-month-old who still is gripping with their toes when they're standing,
Mm-hmm.
or even in sitting, you see them gripping with their toes. So plantar grasp is still active. That's strange at 14 months. But if I touch the bottom of their foot, they pull it away. And so, like, I'm trying to stimulate perhaps Babinski, and they're giving me a flexor withdrawal, or Babinski, and they're giving me a plantar grasp. So I'm asking for one reflex, and they're giving me something completely different.
Right.
So in that case, that Babinski and those other reflexes aren't going to fully get integrated because the wrong answer is being provided. And so in order to integrate the reflex, you need to experience it. You need to experience that this is the tactile of Babinski, and then my toes are going to flail, and I'll supinate my foot. So, but if that's never happening because a wrong answer is being provided, I don't care how many times you stimulate that reflex at what you've been doing, it's going above what the child can handle, and you're getting the wrong answer. So we need to walk it back and see how much can I stimulate where maybe I do get a little bit of that. And this is happening with a couple of my older kids that I'm working with. One girl has Angelman syndrome, and she's on her left leg only. She's rolling in and walking on the medial aspect of the foot, only on the left leg. So, okay, her right foot relatively understood the information, but she is not. Every time I try to put that lateral border down, she just picks it right back up and like starts mule kicking me if I'm getting too close, and she gets really upset. It's not that she doesn't want to go there.
Mm-hmm.
She doesn't like the way that feels. That feeling is causing her to do an action.
Right.
And then in any other time that she's allowed to, she's going to be off of it.
Mm-hmm.
It doesn't feel right. And it's not giving her the information, the sense of, now we can talk, what is that sense? Is it the sense of touch through like just through the pads of her foot or through her skin, or is it proprioception, or is it the stretch of her skin, or is it the stretch of a ligament, or like I said, the receptors in the joint? So what part of that information isn't feeling okay?
Right.
And so when we think about proprioception, we think of it pretty globally. And also, and what's your definition of proprioception? Just because I'm just curious.
Yeah, I would say just your body awareness and knowing where your body is in space without, just by the way it feels and not looking at it. So your experience of your body in your environment.
Right. I would agree that that's what I used to think too, like stop there. So yeah, so like close your eyes and tell the kid to close their eyes. And if you bend their elbow, that they know that they're been elbow bent, and that you straighten their arm, and you know that that's straight. But again, we go back to safety, that I feel safe in this extended position. I feel safe with this amount of stretch through my arm or pressure in my arm. And I know what that information is telling me, something that I'm attending to. And again, not in a necessarily a known sense, but in this felt sense, I'm feeling okay to gather that information about arm being straight and move forward to use that in my world, as opposed to a child who has no body awareness or have poor proprioceptive awareness. And as soon as they feel a shift or change in their joint, they have to protect themselves or get out of there,
Mm-hmm.
or move their body so they don't feel that, or it turns off, that low tone. So that the energy that should be running through our muscles at rest should be where we can access it, right? That I can use my body against gravity, that I'm not being pushed over by gravity, or hypertonic, that I'm not pushing myself out into a position that I can't control because the tone is so high. So now, no matter how much I want to move my arm, I have all this energy that I have to overcome first. And that's a lot of effort and a lot of work. And I can't. And as I start to do that, there's that feedback of there's a lot of tension there, and that doesn't feel good. So I'm just going to stay here because this actually feels better.
Right.
So it's not that they want to stay here, they don't want to feel this.
Right.
And that, I would say, even like with kids with torticollis or children who are having maybe their hip height, their leg lengths look different. And so we're wondering, well, why you're 13 months old and you have one leg that's shorter than the other? Like, you send them to ortho and their femur lengths are the same. The doctor's like, I don't know. It looks normal to me. Then maybe they'll grow later. Or I had one doctor say, well, we can do a surgery where we cut off part of their tibia.
Wow.
Right.
Like, no, thank you.
Maybe we'll try some other things first.
Yeah.
It's a really successful surgery. It really works,
Mm-hmm.
except for it actually doesn't take the problem away.
Mm-hmm.
So then, because the problem is in their quadratus lumborum potentially, the problem is a spinal galant reflex potentially is causing activity on that one side, hiking that hip up, unbeknownst to the child.
Right.
So, and we can look for, so tone. Okay, fine. So sorry, big tangent. Let's talk briefly about muscle tone, and then I want to share a picture with you. So when a baby is born, we know that most of them have physiological flexion because they were all tied up in there, and that's just the energy in their body. And then as they start to grow, they start to lengthen out, and then they start to show us that they have movement. They can lift their limbs against gravity. So maybe we're saying that they're gaining strength and then they start to be able to move their arms together, their legs together. And then around 3 months, 4 months, they can move right from left. All those things are what we typically expect. So if we come across an infant of that age who is not doing those things, then it is actually those primary reflexes, this TLR of inflection and extension, that is not making sense to the child. And it may have happened previously, or it may have happened in utero, that information, starting in 8 weeks of gestation, we start to make movements of flexion and extension. So if those initial movements didn't make sense, or anywhere along the line that didn't make sense to the child's body, didn't feel right, they're not going to want to go there.
Right.
And so now when they're out against gravity, now things are even worse. So here they're all in the water, and if it didn't make sense in the water, it's definitely not going to make sense on land. And gosh, we know that about aquatic therapy too. And that's like sometimes the insurance will say no to aquatic therapy because they don't see the same results on land. But sometimes we can really get some cool things in the water, and then on land we don't see it. So in here, they probably didn't like this even in the water, and now we don't. Or in the case of kids who are drug exposed, we talk about that interoceptive sense. They were bathed in chemicals that have now put them in that they couldn't get away from.
Right.
And they now, their threshold for handling these chemicals is so low, or for any sort of conflict is so low because of the environment that they were in. So, nature versus nurture. Yes, we have this genetic code, but we as physical therapists, OT, speech, early educators, whomever you are, parents, we can provide an environment to support our kids where they're at by noticing what's easy for them and what's hard. What things do they avoid? What things are they like always doing? And is that helping them with their development or stopping them? And so even if you don't think about any specific reflex, we want to help find where the information from the environment is making sense. Mm-hmm. And we as physical therapists look at those subsystems like vestibular and proprioceptive a lot. Mm-hmm. But I mentioned all the other ones too, because those are other factors.
Right.
A kid who can walk in their home, but they go to grandma's house and they can't, or they can't do it in front of a certain person, or they always arch their back and get mad, unless they're eating or thumb sucking, like they're trying to self-regulate, they're trying to do it on their own because the body doesn't feel right, so they're looking for a crutch. That's giving me a clue that they're still working on integration. If they're in that 0 to 3 range, they're still working on it. But will say, and this isn't something to be shaming or demeaning to parents or therapists or anything, but if a reflex isn't integrated at the right time naturally or with assistance, that sets up that low threshold for the stimulus to come in and for us to very quickly fall into that fight or flight mode. So what happens in your body, Marlene, when you go into that fight or flight mode?
I take off.
When your adrenaline, you have an increase in adrenaline, you feel maybe like your heart is beating, you have to breathe faster, you have to work, there's increased stress. Yeah. And that's built into us for survival, for if there's really a stress happening. But
Right.
what about a perceived threat?
And if something's perceived, it's still a threat because you perceive it that way. So the same thing's going to happen.
Yeah, the same thing chemically is going to happen in your body. So if your window of tolerance for a particular stimulus is this low, and if you reach that point, you're going to be thrown into fight or flight or freeze, and you're going to be, all of the cascade of events is going to happen. Do you think that kid over time, over years, that didn't integrate a reflex in that first 3 years of life is going to be a really calm, chill kid, or they're going to be stressed?
Definitely stressed. So, but how do you help them if you know that they should have integrated a reflex and they haven't yet? I know we talked about making them calm and alert, and from an emotional standpoint, making them feel safe in their environment.
Yeah.
So what manual things do you do as a therapist to help them get these reflexes integrated?
So going back and seeing what they know, seeing what their body knows, what their body can do. And when you see kind of like a block, like, oh, that's interesting that you don't rotate your body. That's interesting that you still are using bunny hopping on the floor at 5 years old. Like they can walk, but when they're in a position of STNR, they're bunny hopping. So there's something at that level is a block for them, because they can access that reciprocal pattern when they're walking, but when they get on their hands and knees in that position, they no longer can. So we would go back to the position, the stimulus of the reflex, which is the position of the neck in symmetrical tonic neck reflex, and work on, well, where do they have reciprocal motion? That boy who stares at the fire does this. So he's 14 and he just W-sits all day long and bunny hops. So if he's standing and walking, he's walked in a very crouched gait, medially rotated onto his insides of his foot, even while wearing his AFOs. And I just started working with him in May, as he moved to this other foster family. But so we have started like working on being on his hands and knees, which if he's on his hands and knees, he can't lift his head. I can entice him, but as soon as he lifts his head, he sits back onto his head. So what can he do? He can work in tall kneel, and he can reciprocally move his legs in tall kneel. So we're starting there. We're pushing his wheelchair to get a little piece of a cracker, and we just go back and forth to build up this ability to support on his hands, be in extension of his neck. Right now we're an extension of his hips and flexion of his knees, and being able to move left from right, left from right. After this becomes more regular for him, we'll start lowering the surface that he's pushing. or I'll start working on him in quadruped looking up. He'll have a little more control and ability to do that. This is where that neurogenic inhibition goes, because I can put him in this position of tall kneel, and I can ask him to work a little bit harder against some resistance. And depending on what he does with that resistance, will give me an idea of what he's ready to do as far as maturing this nervous system, of creating new pathways. So resistance will always be met with resistance. That's a good thing. And even just thinking about, object in motion stays in motion until an equal opposite force reacts against it. And so if I'm looking for ease and flow, I want this energy between me and the child to just be matching. So I can give just a little bit, that 20-25% of resistance is safety.
Mm-hmm.
And I cannot remember the scientist who said that. It's in one of my books, but that's not me. That's like a scientist person. And now we don't always see that, though. Sometimes we see them pushing so hard.
Mm-hmm.
So there's no safety there yet. They are still feeling like they have to fight against that resistance. So I'll back off a little bit, and what happens? Maybe they'll fall over, or maybe they'll correct. Like now we're drawing a little bit of awareness into their body, this little bit of this noticing of what they have to do. Or for a kid who is hypotonic, I push them over. And so we see this in our kids in working on sitting balance with a kid, and you're giving them a little support to their back, and they just crumble forward.
Right.
Like, oh, that wasn't what I wanted. Because the information you were giving, the amount of resistance you were giving, you were going past what they could do.
Mm-hmm.
And they turned off for protection. Or a kid who pushes against you super, super hard, again, they don't feel safe yet. They are trying to fight and get away from you. Or maybe they'll roll away from you, but okay, so we need to come a little bit back, or I'm working a little bit too hard for you right now. I need to find an easier position. So it's important to understand the reflexes and when they come in and when they should come in, because that's going to help drive what you're asking the child to do. Right. You can't expect a child to do a movement pattern that they don't yet have access to.
Right.
So that's why it's important to know when the reflexes do come in and when they should be integrated. But you still can't ask a child to do a movement pattern that they don't have access to because a reflex is stopping them. At one point, it served a purpose to protect them when they were so little, between those first 3 years of life, they didn't have enough strength or coordination to get something done. So, stroking the side of the baby's cheek, rooting to make them turn to look for the breast. Well, that was helpful because the baby doesn't know that they need to find food. So that was helpful. But if that happens now every time that you turn your head when you feel something to the side of your cheek and you're 4 years old, well, that's going to be a problem.
Mm-hmm.
If that's all it took to,
right.
now you're like looking around all the time. So reflexes, they don't go away. They become integrated so that I can choose. I don't have to listen to the sensory stimulus and then automatically do something, which is what a reflex does.
Right.
Do you know if there's any time when you open your mouth when you're concentrating?
When I'm putting mascara on, I open my mouth.
That's interesting. Have I talked about this before? Yeah. So why do you think you do that?
I don't know. I've tried to close my mouth and I'll close it and do it, and it doesn't feel comfortable. So it's just more comfortable for my mouth to be open, and it just automatically happens, but I can still choose to close my mouth. It just feels awkward.
Yep. Okay. So does that happen when you do eyeliner?
Probably.
Maybe not though. Like I watched this morning, it's not the eyeliner. So we hold the eyeliner pencil here. We hold the mascara here.
Mm-hmm.
So this is going to be stimulating Babkin-Palamental. And so your Babkin-Palamental reflex is not fully integrated.
Oh, man.
But it's integrated enough that you don't walk around with your mouth open.
Right.
And I've got kiddos on my caseload right now who walk around with their mouth open even when they don't have something in their hand.
Mm-hmm.
So again, wrong answer. So no wonder that that's not closing, that they aren't developing an awareness of their mouth. And like you said, you felt awkward using your hand and closing your mouth. That's strange, Marlene. Maybe you need to get that checked out. No,
I know, right?
or it's just that's your threshold. And if that really doesn't impede your day and you can still be a productive member of our society, it's fine. But it does show that reflexes don't go away. We just had a threshold that was high enough. Mike Jordan,
they're suppressed. They're not gone.
Yeah, you have more control. You have control.
Mm-hmm.
And when you're doing this mascara, you are stressed enough, your body is stressed enough of making sure that you're doing it correctly and not poking yourself in the eye, that level of stress and focus kicked the reflex, that you kicked over your threshold for there.
Yeah, that makes a lot of sense. And I want to talk about tone a little bit more, because I know it's one of the posts that we had in the group, and I had put, because I was always taught and believed that you could not change tone. However, I know you can have like some short-term effects from external stimuli, but not lasting effects. And I know from talking to you and your training, you feel that it can be changed longer term, right?
Yes, and I'll preface this by saying I also agreed with you up until last year. I would have said underlying muscle tone can't change. So I can help your child be stronger, but I can't change that underlying muscle tone. I know that to be false now, that you can change underlying muscle tone if you can help meet that child where they need to be for those very early reflexes, that tonic labyrinthine reflex. So if I can help them integrate that reflex better, that one in particular is really going to drive how I feel against gravity, and how this tonic position, how that safety is going to allow me freedom of movement. Otherwise, I'm being pushed over. For a child who has too low of muscle tone, as that reflex is being stimulated and doesn't feel okay, and feels so much that you are going into this freeze state, like there's nothing there. So whether it is, again, receptively rotations in the joints, or the stretch on the skin, or the vestibular system, there's one of those pieces or multiple pieces that isn't allowing that tonic labyrinthine reflex to integrate. And so if we can go and look at that, and looking at how they come into gravity and can start to move against some resistance, how they can be on their backs and start to move into some resistance, and looking for that, creating that new pathway by using that 20 to 25% resistance of their body. Like, can they create that energy for you? And as they get better at creating that 20 to 25% resistance in positions of moving their body with control into extension, if they're prone or curled into a ball, or on their back, being able to do that again, moving into gravity through flexion and meeting that 20, 25% resistance, that's where we start changing their muscle tone. We're not doing strengthening exercises at that point. We're looking for safety against gravity.
Okay. And then I have another question. So if a child is integrating their reflexes well, and they're over 3, and then maybe later on they have like an upper motor neuron lesion or a lower motor neuron lesion, and since those reflexes were just kind of suppressed, does that change the threshold, and then you start back at what you would do if they were never fully integrated?
Yes. So if we think about, I don't have a picture to show you right now of like your brain and the neural pathways, but they have like one that has like, you can see like how many neurons and axons are growing in the brain, and then after a few months of life, how many more are. And then a 3-year-old, there's actually a little bit less because they're pruned off. So the child who's 3 who has a stroke, injury to their leg, whatever, maybe even a bad virus that they went through, that now looks like they are missing something, or they've gone kind of backward. Yeah, those primary reflexes that were once integrated, or maybe not fully integrated, partially on that way, that pathway exists to a certain degree. Those neurons have grown together throughout the nervous system to a certain point. And now we have this disruption, and the sensory stimulus coming in through any of those 10 pathways is now back into fight, flight, or freeze. And so we do need to go back and work through that. Same thing with trauma, same thing with PTSD, whether it's an adult who experienced something, car accidents, things that even don't physically have like a visible problem can still affect your nervous system. In my first class that I took with the MNRI method, the one girl had fallen out of a tree house and landed on her head at 3. And she was a speech therapist now. And she said, though, she sensory wise, she's just a mess. So I don't know how old she was, maybe, in her early 30s, that, she just forces herself to go to work every day to wear nice clothes. And as soon as she gets home, she has to take off her bra. She has to take off her pants. Like, she cannot stand wearing clothes anymore. And she's 32, but that sensory system was disrupted with that injury. So even though she might have gotten over whatever broken bones she had, there was something that was jarring that set back particular reflexes, spinal gallant, to not allow that information to come in through her senses well and be well received.
Right.
So if we're always superseding our threshold, we're always going over it, we're always putting ourselves in protection. Mm-hmm. The answer is to go right under it just enough to elicit something, but not go over what the child can handle.
Okay. So we know, like we talked about having a upper motor neuron lesion or a lower motor neuron lesion later in life, and then having to like backtrack. And then we also talked about like chaos, emotion, how that can affect your reflexes. And then I think I caught you where you also said that maybe an orthopedic injury can also set you back. So sometimes even in an orthopedic setting, you may have to retrace your steps before doing more of the strengthening and that type of thing.
Potentially, yeah. So I've got another little guy. He's not little, he's 18. But when he was 16, he had hip dysplasia, and his parents really didn't do surgeries initially until 16. They decided at that point it was significant enough. So, and the doctor said that he would be able to do more and be in less pain. Well, actually what happened after that surgery, he didn't recover from that well. And now his abdominal muscles have completely turned off. And so he now sits with this extreme lordosis. And if I try to invite flexion into his spine, he just goes harder into lordosis in his lumbar spine. So a surgery at his hips has unintegrated a spinal pres reflex, and to such a degree that even something that is a positive thing, movement of flexion, is interpreted as, the poor guy, he will bite his hands, and you can just see how, and he has no ability to come back down from that. Like my whole session, if we go there, we went there on Friday, I felt so bad. I didn't mean to push him that far, but I did. So all he learned from that is protection. Everything that happened before that was so awesome until I went too far, and then the learning stopped, and all he learns is protection.
And then, so going back, I'm backtracking again. So going back to tone with reflexes, once you, and I think it probably depends on each person because their nervous system is different and the degree of their either high tone or low tone matters too, and how long they've been in that, and if they're high tone and developed contractures, like,
Yes.
So how would
Or
you,
low tone and develop contractures.
yeah. So once you help them integrate some reflexes, what do you expect to see from maybe someone that is maybe has CP and has had high tone and they have like some contractures? What do you expect to see after help? I guess can you give an example of maybe one of your kiddos, like how you got them to move better, and did their tone change or did they just feel more comfortable going in and out of different positions?
Yeah. So the overall muscle tone does change, and then as you see that being again, depending on their thresholds and windows of tolerance for different sensory stimuli, auditory stimuli, smell, all these things can be throwing them out of that calm and alert. So we can either, so yes, you can watch a child who was traditionally hypotonic or hypertonic move away from those extremes and that automatic movement as the reflex begins to be integrated. But that's often really hard because of what I said earlier, that when the reflex that you expect to see is stimulated, you usually see the wrong answer. So it's confusing at first to try to say, okay, I'm going to go in here with my book and I'm going to look for all these reflexes. And then what you see is like completely different. So you can't just start with that reflex. You have to go back to understanding where at any point do they feel safe. More of these just 6 basic movements of flexion and extension, side bending. Like, let's just see where you have safety in the movement of your body. And then from there, we can kind of go back and look at individual reflexes. But I guess I caution with just getting out your book and looking and testing each reflex, because I'm going to tell you, especially for those kids with severe needs, that they're not going to look like that reflex. You're going to stimulate a reflex and you're going to get something completely different. And so I don't want you to feel confused or like unsure about why that's happening. It's happening because their nervous system is not making sense of their environment. From a basic blueprint level, it didn't make sense from the start. So go back to just what you do know about and see what they can tolerate for movement. What is available in their spine and in their limbs, where we can use our skin as our largest organ to give information of safety. And maybe looks a little bit different than what you have tried, or maybe their parents have intuitively tried something that made a difference. Listen to that. Parents desperately want the answer, and they will try so many things on their own. They just don't necessarily know why. So if they say, yeah, when I put my hands on their chest, he just really relaxes. Okay, that's helping him feel safe. Let's do more of that. Let's see what else that will do if you give that pressure to the chest while we're working on sitting or whatever. Like, start with what you know.
Okay.
Always, if you're working on a math problem with your kids, the math problem, start with what you know and then add on from there. It's the same thing here. Start with what we know and move them 1 degree away from that and see what the response is. If it's positive, then awesome, then we're doing the right thing. If it's not, then let's come back and try it a different way. Lots of trial and error. And I wish I could just say that this is the protocol you're going to follow exactly and you're going to do it. But we know that that's not really.
Right. It's not black and white. And every child's different.
Yeah. And depending on, like I said, you can go into this so much more about how to really help support the auditory system, or if the visual system isn't making sense to the child, like really how to come in and help support them there. And I would encourage you to do that, to find courses that talk about that specifically, because it's more than just proprioception and vestibular and muscle strength.
And And everyone, so this is just a glimpse into the Christine's Sensorineuromotor Education modules. And how many modules do you have?
Well, in that particular class, there's 8 modules that kind of go over this. So yeah.
So if you want to learn more about this and more about what Christine has to offer to teach you, she does have 8 modules. She also has a Pediatric Telehealth Toolbox that you can also sign up for. And I have, so you could go, and I also have it in the description. You can go to sweetppediatricwellness.com, and it takes her to her website, and then you can go for pediatric therapists, or if you put /quote, it takes you straight to the Pediatric Telehealth Toolbox. I don't think your modules are up yet, but they can just email you to see how they can sign up for that, correct?
Yeah, I mean, you should be able to click on the sensory neuromotor course. I need to go back and look at that, but there should be just a separate course that says sensory neuromotor education, whatever. It's $50, I think. So.
Yeah, so that's a really good price, $50 a module, and there is a discount. For the whole thing. Oh, that's a really good deal. You get all 8 modules, right? 8.
Yeah. Mm-hmm.
For $50. So, and there is a discount code, Coffee Hour, and you can use it multiple times for different courses on her site. And Christine, is there anything else that you feel like we didn't cover that you want to talk about?
Well, really quickly, if I can do this, let me see if I can do this. Share. Yeah, let me just show you this picture here real fast. Can you see that reflex?
I don't. Wait, I see something on the bottom here. Maybe it shows up.
Can you add it to the screen?
It just has edit name. Oh, I see what you're saying. Like, just carry it over. Maybe.
Is it in our broadcast studio now?
Yeah, it's in. Oh, wait, here we go. I just had to scroll up. Okay.
Okay. So, so this reflex. This is the bottom. This is the base. We need to integrate our reflexes well, because it's going to help us through sensory information, through those 10 senses, start to develop feelings and emotions. And if we hit our threshold at any point here, we're going to fall right back down into this protection survival state. So here we are, the 2-3-year-olds are developing emotions. We know that. And they can start to, regulate those emotions through awareness, through noticing. And we can help our own clients that we work with, children or adults, to gain more control, gain more coordination over their emotions and sensations and feelings by noticing what they're doing. If we have an awareness of something, then we can either add to it or take away from it. If we're not aware of something, how can you change that? So then we can access our cognition and be talking and moving our body well with good coordination. And if we hit that threshold, we'll just fall back down to wherever that reflex is going to take us. But as human beings, I really feel like we have a higher meaning, a capacity as a human being, not to just get stuck in this brain level here of this like thinking brain, but we have this meaning. And so that belonging, that passion, that purpose, what draws us together. And sometimes it's the case that if a kid is getting stuck here and not wanting to do X, Y, or Z, we can often override that by coming up to meaning and finding what is a shared value. And this is true for our parents too, especially for telehealth. If they're really anti-telehealth because that's hitting their threshold of how much cognitive effort they can put in, and they're falling down into reflexive behavior of canceling your sessions, you can override some of that with shared values, with that passion and purpose of how much you really want to work, help them help their child to meet their goals. So anyway, so this is just like how I organize my thoughts and how these all link together. And yeah, I can get up to emotion and cognition without having well integrated reflexes, but it's a lot of work and it's a lot of falling back down and climbing back up. And that takes a lot of energy and effort. So anyway, if that's helpful.
Yeah, definitely. That's really helpful. And I know we forgot to talk about in one of your modules, I know you talk about turning fear into love. So
Yeah.
do you in that module, do you talk about specific strategies on how to encourage turning that fear into love through their environment, emotionally? Like how do you?
Yes, for sure. And when I say love, like it's that unconditional love, that agape type of feeling, and just being able to notice that in your own self. A lot of this starts with you as the therapist or you as the parent noticing where you are at. Because if you don't have an awareness of where you are at, you're probably acting pretty reflexively too when you hit your threshold. And maybe not in primary reflex land, but with stress and with difficulties. And so noticing in our own selves what triggers us and what pulls us back into fight or flight is really important to start removing blame and shame, and helping us just be okay with what's going on. And so I take that from my yoga background. And so that turning love into fear really teaches you about how to create that space for yourself, so then we can have that space for the clients and parents that we work with.
So I think that was a great way to, like, talking about turning fear into love is a great way to wrap it up. And I definitely feel like everybody should check out these modules, and only $50, and you get to learn more about sensorineuromotor. I have to like think when I say it, sensorineuromotor education, and discount code coffee hour. Thank you so much for coming on today, Christine. It's been a pleasure, and I always learn something new. Christine has become a friend and a mentor to me, and I definitely would recommend her courses.
Thank you, Marlene. It was a pleasure being here.
Thank you. And bye, everybody.